And hi, Shireen. Good to see you. Thank you for being here. I'm going to go ahead and just get this webinar started. I'm Bianca Frogner. I'm a professor at University of Washington in Seattle. I'm also the director of the Center for Health Workforce Studies. And more importantly for this, I'm part of the Award Network committee, leadership committee, and I'm the chair of the webinar committee. And I apologize. I'm dealing with a little bit of a chest cold, so I'm sounding a little rough this morning. I'm really excited to have this webinar today, a fantastic set of panelists where we'll be talking about co-designing long-term care research work. And so Shireen Villani will be our MC for the day. So as part of that, I'm going to pass it on to her after I go through a little bit of house cleaning here, and then she'll quickly pass it on to our panelists for today, who will go ahead and introduce themselves accordingly. And then we'll leave some Q&A at the end. So thank you again to everybody who's here today. So I'm going to go ahead and do some house cleaning here. If I can get my slides to move, apologies. We have a webinar next month as usual, but the topic is different than what I announced last time. We just switched around our speakers for November and October. So in October, we'll hear from Joanne Spetz, our fearless leader for the Award Network, and Donovan Moust, who's at University of Michigan, who are the co-PIs for the National Dementia Workforce Study, which many of you have probably already heard about from either the webinars or through the Award Network mailings. But this is a large effort that's underway, and the data are soon going to be available. So in October, there'll be a discussion about some of the details of the study. The day before, there is a webinar for the National Dementia Workforce Study about these pilot grants that have been released. And in that, you can learn more about the pilot grant. And then in our October webinar here, you can learn more about the study itself and the details of the survey, all of which are available online at this point in time, that you can see the instruments themselves. Now, these are different pilot awards than what the Award Network does offer, which some of you in the audience may have received. And the Award Network pilot grants will come back around next year. So certainly keep an eye out for that. We'll be doing that again. And as always, we always welcome ideas for future webinars, which you can get, you can enter them by entering the QR code that you see on the screen. You can also see what our future webinar lineup is, as well as see all of our prior webinars that are recorded and posted to the website. Another save the date here. I mentioned it last time, but I'll mention it again here in November. If you're coming to the GSA, the Gerontological Society of America meeting, it's here in Seattle, my lovely hometown here. We have a location. The meeting will be from 1 to 4 p.m. So we hope to see you there for a fantastic networking event. Again, I want to thank our webinar committee members who are really been doing great work to help bring these webinars to you all. So thank you to all of them. And to our leadership committee of the Award Network, who help make all the activities of the Award Network come to life. And then lastly, thank you to NIA, who is funding the Award Network, including the webinar series. But of course, all the views expressed in the materials do not necessarily reflect the official policies of the Department of Health and Human Services or NIA. So with that, I'm going to stop sharing my screen. Villani, do you want to just take a moment quickly to introduce yourself, and then we can pass it on to Jennifer, who will go ahead and take it from here to do our panel for today. And we'll have you do the Q&A, Shireen, if that's possible.
Yes. Thank you so much, Bianca. My name is Shireen Villani. I am a nurse practitioner by training, and I work at Toronto Rehab in downtown Toronto as NP and researcher. I would like to get started. I'm quite delighted to introduce Dr. Jennifer Battelle, who is a colleague and a great mentor to me. The whole team is from home, Ontario, Canada. They'll be presenting on, the title is Nothing About Residents Without Residents, a research project about co-design in long-term care home settings. I'll introduce Jen, and then I I am hoping that other team members will introduce themselves. So Dr. Jen Bathel is an affiliate scientist at Kite Research Institute at Toronto Rehabilitation Institute. She's an epidemiologist and health services researcher with research interests in aging, social connection, mental health, long-term care home settings, and patient engagement. She is co-lead of the engagement of people with lived experiences of dementia, cross-cutting program of the Canadian Consortium of Neurodegeneration and Aging. And the presentation will be predominantly delivered by Dr. Bathel with the great panelists present with her today. So Jen, the floor is yours to take over.
Great. Thank you so much, Shirin, for the introduction, and thank you everyone for the invitation. And I should just clarify too, I'm actually going to cover the first few slides, but it's really a co-presentation the whole way through. So we're really excited to be here. Thank you for joining us. Thank you for welcoming us. And we're going to speak to you about our project, Nothing About Residents Without Residents, a research project about co-design in long-term care home settings. And I'm going to start the presentation, but each one of us is going to introduce ourselves as we go through. Next slide, please. So I'm coming to you today from Toronto, Canada. It's the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Haudenosaunee, and the Wendat peoples. And it's now home to many diverse First Nations, Inuit, and Métis people. Together, let us now pause as we acknowledge the Indigenous peoples of all the lands that we are on today, from wherever we are virtually participating in today's meeting. Let us take a moment to acknowledge the importance of the land we each call home. We do this to affirm our commitment and responsibility to improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. We acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people who call this nation home. Let us now join in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how each of us, in our own way, can move forward in a spirit of reconciliation and collaboration. So we have about an hour today, and we're going to work through our presentation, hopefully in about 45 minutes, and leave time for questions at the end. So as I mentioned, I'm going to start us off. We're going to go through some introductions and some background to the project. We'll speak to some of the results from AIM-1, which was a scoping review. We'll speak to some preliminary results from AIM-2, which was really some interviews with residents, staff, and administrators. We'll talk about next steps in the co-design process and then a conclusion. And first, I really want to acknowledge our funders, the Canadian Frailty Network, Pearly Health, which is in Ottawa, Canada, and the Canadian Institutes of Health Research. So introductions. As Shirin mentioned, I'm an epidemiologist. I'm a researcher. I live in Toronto. I should say I've never lived or worked in a long-term care home, although I've done research in homes directly, which has been a privilege. And I feel very strongly that our home and the way we feel in our home is such an important driver of our health, of our well-being, and our quality of life. Jim, I'm going to pass it to you to introduce yourself.
Good morning. I'm Jim Gilholy. I'm resident in a long-term care facility in Kitchener, Ontario. I have been here for 4 years, 7 months. I came in just at the beginning of the COVID alert. I had 1 month of normality, and then the world turned upside down. I am in long-term care because of I have muscular dystrophy. It restricts me to a wheelchair and the use of one hand, one arm, a bit of neck muscle. It has also sharpened and focused me so that I've got a few things to say, and we'll get on to that later. The reason I'm doing this is, one, for myself. It helps me to focus, and I do people that live with me and the people in the long-term care around the province. But I'm also doing it for you, the audience today. I will recite a little bit of the mashup that I have of some Irish poetry. Rider, cast a cold eye on life. Cast a cold eye on death. As you are now, I once was. As I am now, you will be.
Thanks, Jim. And Gail, can we ask you to introduce yourself?
Yes, absolutely. Thank you so much. I'm Gail Ramsden. I have also been in long-term care for 4 years or so. And like Jim, the reason that I am here is for a physical care requirement. There is nothing wrong with my acuity. And because of that, I think the gaps and cracks and challenges within long-term care are very obvious to me. And I've been moved to become a bit of an advocate for trying to see change, positive change, corrective change in long-term care to make the life of the residents living in long-term care the best it can be, and also to speak for those who are unable to speak for themselves. So I find outlets like this are in line with that goal of mine, is to spread the word, try to educate, and perhaps along the way enjoy one or two aha moments where someone in the audience might suddenly realize a truth that hadn't even occurred to them before. Thanks, Jen.
I will go next. Hi, my name is Chloe. I work for the Ontario Association of Residents Councils as their Quality and Evaluation Specialist, and I'm a research coordinator on this project. I work very closely with Jim and Gail, and although I haven't worked in long-term care before, it's been my honor to work with a lot of our resident volunteers with ORC to just promote their experience and their voices to various policy tables and research circles.
Thank you. I guess I will finish us off. My name is Molly Hutchinson. Good morning. I am a summer practicum student with the Ontario Association of Residents Councils. So I'm just going into my second year of my master's in public health at the University of Toronto. And I had the absolute honor and privilege of learning from this incredible team and from Jim and Gail and so many other residents. And it's really, although I have not lived or worked in long-term care before, this experience has certainly given me a lot of inspiration for continuing in a field that includes long-term care homes and long-term care residents. And my main responsibility this summer was to work on the project that we'll be talking about today.
Thanks, Molly. So I'm not gonna introduce each member of the broader research team, except to say that it includes researchers, it includes clinicians, it includes trainees, it includes people who are currently working or have worked in the long-term care home sector, and of course, residents. And next slide, please. I'm going to briefly introduce the Ontario Association of Residents Councils. So as I understand it, Ontario is somewhat unique in the sense that it has an organization that is supported to really support residents' councils and residents' rights across the province. And it's been active since 1981. It works with residents, it works with homes, it works with policy and decision makers really to further the mission of the Ontario Association of Residents Councils. So Ontario is, you may or may not know, Canada's largest province population-wise. There's about 14.5 million people living in the province of Ontario, and there's about 39 million people living in Canada, which is about the size of California. But within Ontario, there's about 76,000 people living in long-term care homes. There's 627 long-term care homes across the province, and each one of those homes is legally mandated to support a residence council in their home. So what do we mean by long-term care homes? In the context of this project, in the context of the Ontario health system, we are talking about residential centers that provide 24-hour care and services to the people that live there. But they're also commonly known as nursing homes, continuing care facilities, residential care homes, or care homes. But in this project, we're really talking about residential care. And what is resident engagement in the context of this project? So we're going to drill down on this a little bit more in the next slide, but it's really about involving residents in their home, shaping their home environment and shaping the home that they live in. And some specific examples are residence councils or committees, but really the substance of the presentation and the substance of what we're going to talk about today is really unpacking that a whole lot more into different ways residents get engaged in their home. So to drill down on the details, as a researcher, I love this slide, but it's perhaps not everyone's favorite. But just to highlight the point that engagement can happen at, excuse me, multiple levels. It can happen at the level of the resident, it can happen at the level of the home, and it can happen at the level of the system. And engagement, there's a continuum of engagement. And what we're focused on for this project entirely is not direct care or resident level engagement or system level engagement. It's really thinking about engagement at the home level. And we slice that a little bit further and to say we're not interested in instances or examples of residents who get surveyed in their home or surveys as part of quality improvement, but it's really these active roles as advisors, as committee members, or as contributors within the home. Next slide, please. So why is resident engagement important? This is where I hand it over to our resident experts, Gail and Jim.
Yes, hi. I won't read the bulleted list because you guys can do that for yourselves. But what I would like to point out is a couple of things that for me resonate on why resident engagement is important. And the first thing for me is stimulation and sense of purpose. Residents living in long-term care, when they are unattended to emotionally, mentally, spiritually, etc., are living in a vacuum, devoid of purpose, devoid of a sense of accomplishment or achievement, devoid of stimulation. And to me, those are some of the most powerful reasons why resident engagement is important. And the second thing for me that is the most important is that residents want to collaborate on creating an environment that they would like to live in. If you have never lived in a long-term care home yourself, or you've only worked in a long-term care home, how do you know what it's like to live in a long-term care home? And the best way that I can think of is to simply ask a resident. So those are some of the most important things for me. There are other things as well, which we might get into a little later, but I don't know whether Jim's got anything to add to that or not.
Oh, you know me, Gail, always. The word that has come to me a great deal to me lately is co-design. This is a academic word that I had trouble with at first. It seemed to me kind of ivory tower thing removed, and you've changed the language because I thought I knew what co meant and I thought I knew what design meant. But actually, when you fuse the two words or the two concepts, you get a way of establishing a better answer to a question if a power that is greater consults a power that has much less power. And things can work out better if the needs of the lesser group are taken. I believe in consensus, and the consensus affects things. Even people that are very dedicated and are committed to serving people that are less able have blind spots. For example, we've had signs put up at a certain height, and they're quite legible, except for the fact if you're sitting in a wheelchair, then you can't see them. Now, a simple consultation would have moved them down where everybody. The word equity is strange. The word came to have meaning to me with a simple cartoon. It's a father and his two sons standing out in left field watching a sandlot baseball game, and there's a big wooden fence in front of them. And they each have a wooden crate. The father doesn't have any need for this crate. He sees very well over the crate. The older son standing on the crate has a good view. The youngest son stands on the crate and can't see anything but wood in front of him. Equity means redistributing those crates. But don't take the father's crate and give it to the younger son, and he can now see. And all three of them can enjoy the ball game. They all get to participate. Everybody's need is answered. And this is what we're talking about with resident-focused decision-making. We're moving in many ways towards person-centered care. One of the decisions that we made here locally that worked out very well was the painting or repainting of the walls. Residents were involved in selecting colors that they liked and that were good for them and were stimulating, were not institutional looking. And so if you're going to call the place a home, everybody should have a voice in the operation of the home. I don't think we're asking to make the decisions for anybody, but we have something that the other people do not have, and that's lived experience. And it's not sufficient to walk a mile in somebody else's moccasins. You have to live within it for a length of time. And it's only after years here that I've been able to say that, hey, you need to have a resident voice in that. We don't want to make the decision. We don't want to run the place, but we want to have our needs addressed. Simple, I hope, but challenging.
And I think that's the perfect note to really emphasize why we're doing this project. Thank you, Gim and Jill, for that. And so, as you heard from both Gim and Jill, this is a priority identified by residents, and it's not just Gim and Jill. Of course, we really appreciate their contributions and everything that they, all of the work that they do and the advocacy that they do for other residents. But this is also a need that's been identified much more widely among residents that we've spoken to through OARC's work and also through an environmental scan that OARC conducted that really revealed that resident engagement and organizational design and governance is something that is not perceived the same by staff and by residents, and that really needs to be addressed meaningfully and very thoroughly. It's also in line with a greater culture change movement. So you've heard a couple people mention person-centered care. This is a larger culture movement within long-term care that this project really emphasizes and moves with, and that makes this project very timely. It's also relevant to some updated long-term care policy, specifically in Ontario. There was new legislation in 2021 that emphasizes resident involvement and engagement in organizational design and governance. So this research is really important for ensuring that that engagement is done in a manner that's in line with resident needs, resident wants, and that's really engages residents from step one until the very end. And then finally, it addresses a knowledge gap. So as I mentioned, there was an environmental scan done. And as I'll get into when I start to present the results of the scoping review, we know that we need more information on this. And more than anything, we need the voices of residents that are already speaking about this to be amplified and for their perspectives to be shared. Next slide, please. So we've kind of talked a little bit about AIM 1, AIM 2. I'll just quickly give you an overview. of the project. So this is a 3-part project, and we're going to be talking a little bit about each section. The scoping review is the first step of this project, and it is the one that is the most complete at this point, and it is the one that I worked on, of course, with everyone else on the team throughout the summer. And its purpose is really to synthesize existing knowledge on approaches to engaging long-term care home residents in the organizational design and governance of their homes. Next slide, please. So we conducted a scoping review. I was involved largely in the analysis and write-up phase of this, and I'm not going to get into these steps in detail, especially since anyone who's familiar with ARC-C and O'Malley's steps for a scoping review is probably quite familiar with all of this, and we really want to emphasize the outcomes. But I did want to quickly touch on this stage 6 of consultation, which really occurred throughout the entire process as this scoping review was born, as the vision was created, as the research questions were developed, and as the analysis and the write-up have been done. This has been done in partnership with researchers and residents and members of the OARC team. And so it's been, as well as some consultation through presentations that have been done to the larger long-term care home sector. So just to really emphasize that this project has not been done in kind of a research silo, but it's engaged with all members of the team and members of the community as we've gone through the process. Okay, so what are the scoping review questions? I will read them quickly just because they're really going to guide the presentation. So these were the questions that were established going into the scoping review and what we really wanted to answer with the articles that were identified. So how have long-term care residents been engaged in the organizational design and governance of their long-term care homes? What are the reported barriers and enablers to engagement? How have considerations of diversity been integrated into this engagement? How have considerations of dementia and cognitive impairment been integrated into this engagement? And how has the impact of this engagement been evaluated? So the way that I'm going to present some of these results is to just go through each question and give you a few highlighted tidbits. Unfortunately, I would need hours to go through every single result, but really just to highlight some of the key findings. Just so you have a sense, just so you have a sense for what was included in this scoping review, we were looking at long-term care homes and other congregate living settings. So, other residential homes were also included in this, such as retirement homes, to get a sense for how different environments engage residents. We are looking at resident engagement in home-level decision-making, and we are looking at adult long-term care home residents. We also we included original data, but excluded protocols, reviews, and other types of literature, but that will all be published if you're curious to hear more about that. This is just a visual representation of the scoping review process. So we originally identified almost 9,000 records that were potentially relevant, and through several steps of going through the inclusion criteria and exclusion criteria and doing abstract, title, and full text reviews, we finally came up with 62 articles that were included in the paper, which cover 59 unique studies. So a couple of the studies had multiple articles written on them, but the key numbers are kind of 62 articles on 59 studies that were included in the results that I'm going to be chatting about. Again, I'm not going to get into this in detail, but I just want to give you a sense for the kind of the breadth of research that we're talking about. The articles that we're looking at were published from 1963 to 2022, which is 6 decades of research. So it's a huge span of time that we're talking about. And there were also, most of the research articles were written by researchers, as you can imagine. There were some also written by staff members in the homes that they were talking about, as well as some other organizations and associations, as well as one article that was written by a resident. Something else I want to highlight is that many of these articles were commentaries as opposed to qualitative, quantitative, or mixed method studies. So often these were kind of case studies that were written up by a staff member or a researcher based on their observations, which just kind of helps to contextualize some of the findings that we found, and that not many of our results are more observational rather than kind of written on these more rigorous research methods, which are still very valuable. They're just a bit different than maybe those other types of research studies. And then finally, you can get a sense for kind of where our research is coming from. We did take a global scope, but many of the articles do come from North America and primarily the United States. So now kind of into the meat of the results. You can see here, this is kind of the first research question. So how have long-term care residents been engaged? The majority of the studies talked about residence councils. So those were that's a lot of the work that OIRC does, although they also work with other types of resident engagement. But there were also other kind of types of engagement that were talked about. So kind of general resident engagement in decision making, as well as resident groups or committees that exist outside of a dedicated residence council. And many of these, we looked at a lot of different areas of engagement, but we did want to focus a little bit on those home level areas of engagement. So that was really the focus of our study. So as you can see on the slides, many of the engagements focused on home practices and policies. So looking at different, like sometimes policies regarding hours of operations of the home, like, visiting hours. There were a variety of different practices and policies that were looked at under that scope. There was also a lot of focus on multi-level communication. So 25 different articles talked about that. And that really means communication between residents, staff members, and then administration of the home. So focusing on improving engagement between those kind of three main parties. And then also there were several studies that focused on community building. So resident involvement, and with a focus on improving relationships between residents mostly. So now, what are the reported barriers and enablers to engagement? There were a large range of barriers and enablers that were reported. You can see these are kind of the general categories of some of the most common barriers and enablers. And you can also see that a lot of them come up as both barriers and enablers. So meeting structure and logistics, meeting rooms that are conducive to people being heard and hearing each other, having the right accessibility structures in place and aids in place so that residents and staff members could hear each other and have a really collaborative discussion. So these things come up as barriers and enablers because they were critical to residents being engaged. But if they're done well, they can really support engagement. If they're not done as well, they tend to be a hindrance to engagement. Again, you can see that staff involvement came up as both a barrier and an enabler. So staff interference, sometimes speaking over other residents or having a large degree of control over the topics that were discussed in engagement sessions, was reported as a hindrance. But staff support for resident engagement and amplifying resident voices was also very commonly reported as an enabler, which really demonstrates how staff involvement is critical to the success of the resident engagement initiatives. But again, it can kind of serve as a barrier or an enabler. There are some other examples on here. So cycle of institutionalization was kind of a theme that came up in the research, looking at how support for resident engagement is required to really counteract a lot of the realities of living in a residential institution that tends to lean more towards depersonalizing care and the experience of residents based on how it was built. And then we also talked about fear of retaliation came up as a barrier. So residents feeling that they could not release, residents sometimes feeling uncomfortable with speaking their minds. And then finally, implementation and sustainability. So ensuring the longevity of the engagement process. I want to pause here and hand it over to Gail and Jim. I gave you a very brief overview of some of the barriers and enablers, but often these are barriers and enablers that are experienced day to day. And sometimes there are also barriers and enablers that may not have come up in the research that are very important. So I want to hand it over to Gail and Jim to hear if there are any of these that really resonated with you, or if there are any that you feel like are missing and should absolutely be on this list.
I think it's a really interesting dynamic between barrier and enabler. A lot of times the relationship is obvious, like meeting structure, meeting logistics. Okay, let's make the font size bigger. Let's add microphones so people can hear. Sometimes, however, the solution to the barrier is not as obvious. One of the things that's happened in Ontario recently is we now have legislation that requires all quality improvement initiatives within a long-term care home to have resident involvement. However, you can either embrace that and become a culture change advocate and really embrace the thought behind engaging residents, or you can simply have a token resident, check the box and call yourself done. That's what I mean by a challenge, to come up with an enabler that counteracts the barrier. There are other things within barriers that are obvious and felt by residents that might not even be in the realm of awareness for the management or the administration of the home. Things like, I'm not smart enough to participate in this meeting that is filled with professionals. I'm too intimidated. Nothing will change anyway, because that's what history has taught me. I think, the fear of retaliation is self-explanatory, but very real. So the challenge becomes, how do we create enablers that will encourage resident participation, which is what you require? That's the bottom line. That's what we're looking to achieve, is resident engagement to help form the governance of the home. So the first step is identifying the barriers, and you have to be brutally honest about identifying what barriers there are. Portering residents to a meeting. If the resident can't get to the meeting, they can't participate, but they rely on the home to facilitate that. So being honest about what the barriers are, and then working in an honest and very open and with a culture change hat on to create enablers to counteract some of those barriers. Jim? Maybe he's on mute.
Sorry about that. I was trying to block out the noise from the hall. The people that don't feel that anything will change or can be done are a difficult group, and some of them are very cognitive yet. You surprisingly might meet them in the smoking area. There's a certain rebelliousness that realizes, hey, any engagement is futile. So I think one of the things is sort of a lack of liaison. I try to talk to those people, see what's going on, and then carry through some of those ideas. But, there's a feeling sometimes that nothing will change because there's a certain sense of nobility or purpose in the people that are operating these homes. They believe in themselves, they believe in their mission, and they're noble, but they don't listen because they already know, they know best. And that's a difficult thing to deal with. I had a nurse the other day that I had difficulty convincing her that the bruise that I had on the back of my hand was new, because she said, no, that's an old bruise. You had that last month. And I had to point out to her that the old wound bruise was still there, not completely healed. And there's a reluctance sometimes to believe that the resident knows what he's talking about, and that only father knows or mother knows. And then that may be part of it too, is the ability to identify with the people that are administering the home, that they don't come from a similar background, or they are all women, or the ability to speak and engage with everybody is a difficult thing. And for the staff to do that is going to be a bit of a a change in attitude, and that's gonna, slow steps. So working on them.
Yeah, thank you so much, Gail and Jim. The importance of addressing those barriers and enablers together, and as you both mentioned, solutions that are really genuinely focused on culture change, I think is really the crux of that slide. The details of the barriers and enablers are super helpful for knowing how to implement a solution, but it's really that larger picture that I think we're really trying to capture. So I'm just going to finish up with some of these results. We did look at considerations of diversity when looking at how these different engagement initiatives were engaging residents. And it really wasn't a common consideration. There were very few reports of any kind of attempt to engage diverse residents. And there were very few studies that actually reported the demographics of those being engaged in the engagement strategy, but also in the research. So this is definitely an area for further improvement, since it's incredibly important to know who is being engaged and who is not being engaged in order to make sure that everyone's voices are being represented. This is something that's come up a lot in our consultation, in chatting with each other, and really trying to understand resident engagement is considerations of dementia and cognitive impairment when engaging long-term care home residents. And unfortunately, we didn't see a lot of this in the research. As you can see, 12 studies really kind of got into this topic at all and talked about dementia and cognitive impairment, and including residents in engagement strategies and engagement initiatives that were experiencing dementia or cognitive impairment. There were a few different strategies that were discussed, including all participants, regardless of having dementia or living with cognitive impairment. There were also some studies where residents who were living with dementia or cognitive impairment were automatically excluded from being engaged in an engagement initiative. But really the focus of this as well is that only 12 studies talked about this out of 59, and the majority of those living in long-term care do experience dementia or cognitive impairment of some kind. So this is another area that needs to be a focus if residents are going to be engaged meaningfully and if all residents are going to be engaged. Finally, but importantly, how has the impact of engagement been evaluated? Again, I'm going to come back to the fact that the majority of the studies that we looked at were commentaries. So many of the studies described outcomes rather than reporting outcomes. But as Gail mentioned earlier, one of the things that we care about the most is how does this impact residents day to day? And so although there were a lot of outcomes discussed, as you can see, like organizational level outcomes, community level outcomes outside of the long-term care home, we wanted to highlight a few resident level outcomes. So you can see that increased autonomy, responsibility, and influence were commonly brought up in the research. Increased fulfillment or positivity among residents was commonly discussed, as well as general improvements to quality of life and physical and mental health. So we know that in cases where engagement was being done and there were successful engagement initiatives, these are some of the key outcomes that were described. And these are the types of outcomes that I think, and we all kind of chatted about, like, these are what we really care about. We want all of the levels of the long-term care home to improve, but residents need to be involved. They need to feel heard. They need to be heard. And it is their quality of life that we care about most. So finally, I'm just going to chat through some research limitations. So we really focused on home level engagement, which does not kind of address the system level challenges that are experienced in long-term care, whether it be long-term care staff, administrators. We also focused on individual engagement initiatives outside of the context of the larger home. And of course, research articles only tell us part of a story, which is partially why we have an interdisciplinary and multi-experience team. But even then, we can't see the whole story just from the research. And then as well as some research gaps. So I'm actually going to hand this over to Jim and Gail to talk a bit about some of the research gaps.
Gail, you're on mute.
Thank you so much. I'm so sorry about that. When I think about research and research gaps, I think in terms of a few of the papers that were analyzed for this study that we are presenting today. And some of these papers were written in 1980, 1990. And for me, as a person living in long-term care, I find this really discouraging that the issues that were written about 30 and 40 years ago still exist in long-term care. So, people always talk about change begins with one small step. To me, that's not good enough, because one small step will take until the year whatever to resolve itself. We don't have the luxury of that. So for me, that's a huge thing, is timing, and timing of change, timing of research, in fact, because I know that is, that's a really long period of time. Obviously, the lack of residents involved in the research is huge. How can you do research on long-term care or living with dementia or living with cognitive impairment if you don't involve residents? And the lack within the research process, the lack of having an implementation plan and a calculation for success built in to the research. How can you measure the effectiveness of the research proposal if you don't have a measurement plan, an implementation plan, and a measurement plan in place? A paper without a plan, to me, is just an idea. It's not a plan. It's not a plan until it has measurements in place. So I'll get down off my soapbox now. But I feel very strongly about those things in terms of research gaps, in addition to the other things that are on the screen. Thanks.
Thank you, Gail.
Research is a difficult area, because for years, the only valid form of research was empirical. You had to be able to reduce things to numbers. And about the only thing in LTC that can be reduced to numbers seems to be the bottom line of the finances. If you're looking at quality, how do you measure quality? How happy were you yesterday? Well, there's a different kind of research that's gradually being accepted, and that's ethnographic. I can remember working with one of my teachers on his doctoral dissertation. It got rejected by the outside reviewer because it was not based on hard facts. It was based on opinions. And what his drive was to analyze the difference between successful illiterates and unsuccessful illiterates. Why were some people able to succeed in the world in spite of, or maybe even because of, being illiterate? The outside reviewer said, you can't do that. That's just opinions. Opinions aren't important. Now, if the research comes around to look at something more personal, then they can get it. The LTC has to be very personal to be able to be capable of reform. It has to be sort of one-on-one. You have to have an interest in stimulating. You have to have an interest in letting people live the best possible life that they can live. I think one of the mantras that, and this will be very familiar to Gail, that one of our colleagues constantly reminds us, and she's 91 and she's fully cognitive, and she says, I came into LTC to live, not to die. And how do you measure liveliness? Well, I guess you interview people and you have details that recognize that ethnographic research is equally valid and maybe more valid in this situation. Thank you.
Thank you both so much. And you kind of covered all of the recommendations. The bottom line is involving residents in the research process and also ensuring that residents are involved in an implementation plan and not just kind of discussing the idea of resident engagement. And so that kind of comes back to our title of Nothing About Residents Without Residents in the research and in the implementation. So I'm going to hand it over to Chloe now.
Thanks, Molly. And so our second aim of the study was to do some qualitative interviews. And the purpose of these was to measure the community capacity, especially in Ontario's long-term care homes, to implement a tool or program that would enhance resident engagement at that organizational level. We started recruitment back in May and had rolling interviews on a rolling basis up until the end of July. So in the end, we had 27 participants. Approximately 41% were residents, 18% were administrators, and 41% were team members, so people working in long-term care. Most of our participants were white, had a bachelor's degree as their highest level of education, identified as being a woman or female, and spoke English as their first language. And some of our preliminary findings from these interviews, I will preface, as Gail had already mentioned, probably won't be surprising for anyone living or working in long-term care home. They are quite consistent with what we found with the scoping review as well. For example, that food and programming is the primary and most common area in which residents are engaged. It's the recreation staff and social workers who facilitate and support resident engagement the most. And then something else that came in the interviews that was quite interesting was that participants also tend to mention about the home's culture and the ability to make individual care decisions, which seems to suggest that resident engagement at the home level can't happen in isolation. It really coincides with the home's overall culture and valuing resident autonomy. And then a couple other factors that, again, were consistent with the scoping review that either hindered or helped resident engagement were the residents' individual characteristics, such as their own cultural values, their previous career, their personality, how well the home communicates with the residents, and how easily residents are able to access the home's team members and leaderships to also communicate back to them their needs, their wants, their ideas, and suggestions. And as well as staff satisfaction in the home was a factor, and external rules and regulations that govern the home. And so our final phase of our research study, AIM 3, starting this fall, will be to co-design a toolkit. And so we are using the RE-AIM planning framework and also doing this with residents and administrators and team members through focus groups, as well as some of OARC's pre-existing committees. And I will turn it back to Gail and Jim for the final word.
Final word, geez. I think, we've covered an awful lot today, and I think we've probably talked about almost everything that needs to be attended to or addressed or improved upon. For me, if I think in terms of research, I talked about that already, implementation plans and measures of success. I think we've all acknowledged through this process the absolute requirement in today's environment of having to consider the impacts of diversity, ethnicity, mental status, those kinds of things when we look to creating a home that is somewhere that people want to live. And I think that we have a long way to go. If you talk to population today, society today, and mention going into long-term care, it's received with horror. Oh my God, I'm so sorry. You have to go to live in long-term care. We have to change that. We have to change that, because for me, this is my home. This is where I live and should be thriving and should be happy to be here. And when a neighbor comes to me and says, oh, guess what? I'm coming to live in long-term care too, it should be something that is met with some level of excitement. It should just be considered the next stage of your life, not, as Jim had pointed out a few moments ago, not that place to which you go to die. And I guess for me, those are the things that I'm most passionate about. Thanks.
There's a certain amount of urgency presently. We're looking at the beginning of the gray tsunami. That there's an awful lot of people on waiting lists locally. The place I'm staying at, it's been over 800 for the last while. And the people that are coming in are in greater need. And I think we need to see this as a community response, a community problem, a health response. We need to balance a healthy body with a healthy mind and try to get that as much as possible. But there's just such a large influx coming this way. The staffing will be a problem. The retention of staffing will be a problem. There are easy solutions, but you can't take them. And that is to treat the long-term care as a temporary warehouse. You have to make it humane. You have to make it something that people see as natural. And that's going to cause a lot of adjustment. So thank you for listening to us, and I hope we can plant a few seeds to make some changes.
Thank you, Gail and Jim. And so if you have more questions about the research, you can contact me. My email is here, and there's a QR code if you would like to look at our protocol paper.
Thank you so much, Chloe, for this information. Thank you to the entire panel for a fantastically thoughtful conversation. I did see one question come in, but it's really a comment just saying that they appreciate the co-design approach and thanks for the detailed discussion on your thoughtful process. It was great to just see this integration between researchers and residents. And Gail, I really appreciate your comment that we need to think about long-term care as a place that people are excited about going to, not as a place that we dread to send our loved ones to or for us to enter ourselves. So very powerful words all around. Thank you to you all for being here today. I know we're at the top of the hour here, and again, I hope you all have a wonderful day. I hope everyone here who had a chance to listen shares this out with other colleagues and follows up and listens to or reads the paper that's come out. I know I'm certainly very excited to look at that myself in detail. So thank you everybody for a wonderful for being here and for a wonderful webinar, and have a wonderful day, everybody. Take care.
Thank you.
Thank you.